Evening, everyone. I welcome all of you to the academic session hosted by Spice Road Karnataka chapter. I'm Dr. Akshaya, serving as the State Secretary for the Spice Road Karnataka State League. I just graduated last year. I'm working at Rashwatana facility. So I welcome the presenter for today, Dr. Fatima. She's a second year DNB resident, family medicine at Rangadore Memorial Hospital. And the moderators for the session, Dr. Laxmi, she is the HOD Department of Family Medicine. She's an internal medicine specialist. And I welcome Dr. Mallikarjun Sakpal, sir. He's a hepatologist, transplant physician working at the Aster hospitals. He has completed his MD and DM from PGI Chandigarh. So I hope we'll all have an interesting session and we get to learn a lot today. Welcome you all. Fatima, I think you can introduce yourself and start.
I just had one thing to add. Dr. Mallikarjun also was a part of our national conference in 2019. So we had a session together and we had presented a case, a series of cases together. Yes.
Okay.
Welcome, Dr. Laxmi. Over to you, Fatima.
Okay, ma'am. Ma'am, I am Fatima from second year DNB Family Medicine resident, Rangadore Memorial Hospital, ma'am. Shall I start, ma'am?
Yeah, please start.
Ma'am, my patient, 54-year male who is married, was working as a security in a paper company in Chamrajpet, Bangalore. He presented with complaints of abdominal distension 3 to 4 months, yellowish discoloration of the urine and eye 15 to 20 days, swelling of the bilateral lower limb 8 to 10 days, fever for 5 days, and breathing difficulty for 4 days. History presenting complaint. He was apparently normal 3 months back. Then he developed abdominal distension for 3 months, which is insidious in onset and gradually progressed from flank fullness to generalized distension, which is associated with fatigue and loss of appetite. There is no history of lower limb edema, facial puffiness, and orthopnea initially. There is no history of fever and abdominal pain and constipation and loose stool. For the past 3 months, he was irregular in job because of the above mentioned complaint and didn't seek any medical treatment. Then attendant noticed deep yellowish discoloration of the both eyes and deep yellowish discoloration of the urine for 15 to 20 days, which is insidious in onset. There is no history of itching of the body and pale colored urine. And bilateral lower limb swelling for 8 to 10 days, which is insidious in onset, gradually extended to knee and face. There is no history of lower limb redness and pain. Fever for 5 days, which is intermittent in nature, associated with chills and rigor, which is got relieved by antipyretics and no diurnal variation. 4 days before admission, he developed breathlessness, which is insidious in onset, gradually progressed from not troubled by breathlessness except on strenuous exercise to stops after 15 minutes of walking at on pace, which made him to quit the job. There is no history of cough, chest pain, palpitation, orthopnea, and past history of PND. There is no history of nausea, vomiting, dysphagia, dyspepsia, heartburn, and flatulence. No history of black-colored motion, vomitus, and fresh blood in stool. No history of altered sleep pattern and altered sensorium. No history of decreased urine output. No history of weight loss. No history of recent change in recent drug intake, injection, tattooing, recent blood transfusion, traveling, and no multiple sexual partners. Past medical history. Patient is diabetic and hypertensive for 12 years on regular OHs and regular antihypertensives. There is no history of IHD, TB, bronchial asthma, liver and kidney disease, connective tissue disorders, peripheral vascular disease, and thyroid diseases. Past surgical history, there is no past surgical history. Personal history, patient is a vegetarian, appetite reduced, smoking around 40 years, 15 cigarettes per day, and 30 pack years. Alcohol, half pint of beer almost all the day of week on an average of 60 gram of ethanol per day, and last drink was on 2 days back of admission. No history suggestive of major psychiatric illness for the alcoholism. No major cut downs. Get annoyed and denies guilty, and occasionally can start early morning drinks. Sleep is adequate. No bowel and bladder disturbances. Drug history. Patient is on tab amlong 2.5 mg OD and tab diamicron 30 mg half OD, and there is no drug allergy. Family history. Both parents are diabetic and hypertensive. There is no history of liver or kidney diseases among family members. Socioeconomic status. He is from upper lower class according to modified Kupusamy scale, and total score is 10. Summary of the history. 54-year male, diabetic and hypertensive, chronic smoker and chronic alcoholic with significant ethanol consumption, presented with abdominal distension and deep yellowish discoloration of the eye and dark colored urine for 15 to 20 days, and bilateral lower limb edema extending to knee for a days, 8 to 10 days, and fever for 5 days and breathlessness for 4 days. From above mentioned histories may suggestive of liver pathology. So the main differential diagnosis are alcoholic liver diseases, infective hepatitis, and hepatocellular carcinoma.
Yeah, Dr. Fatima?
Yes, sir.
Yeah, so can you just summarize once what are the differential how you this one come to conclusion that it is alcoholic liver disease?
So patient have chronic alcoholic with a significant ethanol consumption. So after that, patient developed a gradual abdominal distension associated with deep yellowish discoloration of the eye and dark colored urine, and along with the bilateral lower limb edema, sir. So the progression of the distension from abdomen to lower limb and face. So most probably liver abdominal pathology, and along with this alcoholic history and jaundice history, we can mention that may be due to alcoholic liver diseases.
Okay, no, what you mean by alcoholic liver disease? You have to diagnosis means you have to tell the exactly diagnosis. Alcoholic liver disease varies from simple alcoholic steatosis to cirrhosis and its complication. What you mean
Yes,
by
sir.
alcoholic liver disease? Exactly you have to tell us the diagnosis means you are not telling the disease.
Yes, sir. From
Okay,
alcoholic first. Maybe it's start from alcoholic liver steatosis to hepatitis, then
no, that is
liver
all
disease.
pathology. No, I got it. So you have to write a diagnosis based on your history, and you have to tell the diagnosis. Alcoholic liver disease is not diagnosis. It is telling like fever, some acute febrile illness. Okay,
Yes,
acute
sir.
febrile illness means there are 100 causes for acute febrile illness. What you mean exactly by alcoholic liver disease? What is your diagnosis in this case?
He has
Sir,
abdominal
alcohol.
distension. Fatima, he has abdominal distension. So what do you think? Where is he gone wrong? Yeah.
Ma'am, abdominal distension started with abdominal distension, then progressed to lower limb edemas, ma'am.
So is it still steatosis? That is what Dr. Mallikarjun is asking. Sir is asking. Where is it? Where is
No,
the-
ma'am, because patient had the symptoms like jaundice and deep yellowish discoloration of the urine with a fever and breathlessness.
Okay. No. What I mean is that you cannot say it is alcoholic liver disease. You have to tell the diagnosis means it is a cirrhosis of liver and decompensated with ascites. Okay, that is diagnosis, not
Yes,
alcoholic
sir.
liver disease. Okay, that is the diagnosis. Okay. So
Okay, sir.
that you can say based on your available history, alcohol history, but is there any other diagnosis? The second diagnosis you characterize again infective hepatitis.
Yes, sir.
Okay, again very non-specific. What do you mean by infective? Hepatitis means
Infective,
what?
hepatitis mean infection and inflammation of the liver may be due to some infective pathology or non-infective pathology, sir, causes.
No, what you're thinking, you will have to tell again. I'm telling you, no,
Is
diagnosis.
it a,
Infective hepatitis is a non-specific term.
Yes, sir.
say like, is it a chronic liver disease, acute liver disease, subacute? Is it a decompensation? It's a 3 to 4 months old history, no? That is what sir is asking.
Ma'am, for 3 months, maybe it is a subacute liver disease, ma'am. Acute and subacute liver disease.
No, that's okay. What do you mean by infective?
Okay.
Infective hepatitis means for me, it is like hepatitis A, hepatitis B, hepatitis C, hepatitis D, alcoholic hepatitis. Okay, and there are so
Yes.
many types of hepatitis. So what do you mean by infective hepatitis? What is your understanding?
Infective mean any infectious agent causes hepatitis. Like hepatitis B, C, D, or cytomegalovirus, Epstein-Barr virus, like that.
Okay, so okay, you have to tell one. No? You cannot tell like 10. You have to tell which one you are considering based on the history. What you think? What is the cause?
Sir, based on history, maybe hepatitis B, sir.
Okay, what is in the history you got a clue that patient has hepatitis B?
Sir, fever is there, sir.
Fever is there 4 days. How will explain jaundice and ascites for earlier?
Generalized tiredness and weakness and decreased
That
food
can
intake.
happen because of liver disease. That is not indicative of any infection. So you cannot keep a diagnosis of infective hepatitis based on your history.
Okay,
There is
sir.
nothing clue you got from the history to say that there is a hepatitis, first of all. Second, infection. Nothing is there. So infective hepatitis means acute viral hepatitis, you mean to say, like acute viral hepatitis A, acute viral hepatitis B, or acute hepatitis B, where patient present with prodromal symptoms, fever,
Yes,
pain, vomiting, followed by jaundice. That is
jaundice.
called acute viral hepatitis. That we are not thinking at all.
Yes,
Here
sir.
it is a chronic disease. It's going on for 3 months and developing some complications. Okay, so that
Okay, sir.
differential diagnosis you cannot keep at all.
Okay, sir.
Okay, so third diagnosis.
Hepatocellular carcinoma, sir.
So what clue you got on the history to say that patient has HCC?
Sir, gradual progression of the abdominal distension, nausea, decreased food intake and appetite, jaundice, and bilateral lower limb, sir. Edema.
That suggests HCC. That are the features of HCC.
A loss of weight will be there, should be there, sir.
So that's if anybody has weight loss, you should say it is malignancy. So I say it is a carcinoma colon. Why did you say HCC? I say some other carcinoma. What on the clue you got on the based on the history to say that patient has HCC? So again, you cannot bring a diagnosis of malignancy here.
Okay, sir.
Okay, so you cannot say, first of all, history wise, you cannot say that patient has this one. You can say patient has chronic illness, one of the chronic causes for the chronic illness, some malignancy you can consider. Given his jaundice
Okay,
and this one, you can say, but you cannot say patient has any HCC. That difference based on the history you cannot keep. Okay, so
Okay,
one
sir.
first possibility you kept is alcoholic liver disease. In that, you should say patient has I am suspecting cirrhosis of liver because of patient has ascites, jaundice, and there is a significant history of alcohol. Okay. So in your history,
Okay, sir.
you written alcohol. What is significant alcohol history? When you say that patient, when you say that alcohol is significant to cause liver disease, because only clue to your etiology is taking alcohol.
Yes, sir. Sir, for men, the 60 gram per day for more than 6 to 10 years, and female it is 20 gram per day
So how
for
much
6
is
to 8 years.
taking?
He is taking 65 per day, sir.
No.
60.
What? How much of alcohol is taking?
Sir, half pin means around 250 ml, sir.
What is taking?
Beer, sir. He is taking
So
beer.
what is the beer content in 250 ml?
It is around 13 in 350 ml. It is 13.85, sir.
No, no, no. So you should know the different percentage in different alcohol. Okay, so we'll discuss that one later. Now tell me, is there any other possibility? Let's say he's not alcohol, not taking alcohol.
Sir.
Assume. So tell me the other
Yes, sir.
differential diagnosis.
Maybe NASH, sir.
No, 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 no,
NASH.
no. No, leave about liver disease. You have said again. Leave alcohol. Any other possibility you want to keep?
Sir, maybe some liver abscess.
Liver abscess will not
Diabetes,
last for 3
hypertension,
months and
abdominal
there is
distension, Fatima.
ascites will not be there.
Sir, cardiac cause, maybe cardiac cause.
What cardiac cause? Don't be nonsense. You have to tell the diagnosis. Don't tell renal disease. Don't
Yes, sir.
tell cardiac disease. Don't tell CNS. That is very broadly speaking. You have to tell the specific diagnosis based on your history. So can it be a congestive cardiac failure?
Yes, sir. Congestive cardiac failure, which causing congestive hepatitis, congestive liver problem.
So which disease in the congestive cardiac failure present like this? So usually this patient you see in constructive pericarditis.
Pericarditis.
Yes. So those type of, that is the differential diagnosis close in this patient, because
Okay, sir.
they will have ascites as a first presentation. Mild jaundice they can have because of congestion. They can have pedal
Okay.
edema. They can have shortness of breath, and secondary there will. So that should be the close difference. Just you're taking alcohol, you cannot just say that it is cirrhosis of liver directly.
Yes, sir.
Okay. So what percentage of alcoholic develop cirrhosis?
Sir?
What percentage of alcoholics develop cirrhosis of liver? All alcoholics develop cirrhosis?
No, sir. Around 50%.
How much?
No. Okay. 50% means
15.
half of our population will be cirrhotic, Dr. Fatima. Then my OPD will be full. Okay. So just because taking alcohol, you cannot keep that possibility. Okay. So one
Yes.
differential always because you have some alcohol history, that is alcoholic liver disease. Second is congestive cardiac failure, and etiology in that one is type of congestive cardiac failure, constructive pericarditis type.
Pericarditis.
Secondary to tuberculosis are very common. Those who are taking long time alcoholics, chronic alcoholics, diabetics are prone for tuberculosis. Tuberculosis leading to constructive pericarditis, that is present with ascites, pedal edema, leading on to some jaundice is a very, but jaundice will be not a deep icterus what you presenting on the history. That will be very, they will have a bilirubin of 2-3 type, and mild icterus they notice when they see their yellow. This is deep icterus history wise. That is very difficult to explain congestive cardiac related or related to your constructive pericarditis, because deep jaundice we won't see until patient develops cirrhosis. So that exclude us as agonist. So whenever you are saying a patient's differential diagnosis, always should say what is the positive points, what is the agonist point against the those differential diagnosis. Okay. So in this history, do you want to keep anything apart from this? Any others differential diagnosis? So you're on the always history, you are keeping some renal disease, keep on asking why.
Sir, nephrotic syndrome.
Now how it will present?
Nephrotic syndrome will causes decreased urine output, which causes abdominal distension and generalized weakness and dyspnea, sir. Fluid overload.
What is the presentation of nephrotic syndrome? Is it ascites or it is pedal edema?
Pedal, mainly facial puffness will be there. Nephrotic syndrome with hematuria.
Hematuria again plus minus. So again, any kidney disease, as you suspect nephrotic syndrome, will not present with ascites. He has a massive ascites causing to breathlessness. So these
Yes,
are
sir.
nephrotic syndrome causes generalized anasarca. There
Anesthesia.
will be a mild pericardial effusion, mild pleural effusion, mild ascites, mild pedal edema. Overall, there is a anasarca is the presentation with some positive minus negative decreased urine output, frothy urine. Okay,
Yes, sir.
not hematuria is the not the presentation.
Hmm.
So that's way you can keep it, but not in a patient who is presenting with massive ascites.
Ascites.
Yeah, so his presentation is ascites is the dominant symptom. It is leading to breathlessness.
Sir,
That won't
anemia.
happen in.
Yes, sir. Nephrotic syndrome.
Yes. Any other differential?
Sir, anemia, hemolytic anemia.
How that will explain your ascites?
Just look at causes for ascites only, no?
Sir, any intra-abdominal mass?
No, that will not explain ascites. So other type of presentation presenting with acute onset jaundice, ascites is Budd-Chiari syndromes. So there is acute onset of hepatic vein occlusion, which lead what we called as acute Budd-Chiari. That present with pain abdomen, jaundice, and ascites.
Yes, sir.
Fever plus minus they can have it. So that
Yes,
is
sir.
one as a presentation. Other presentation, sometimes it happen if the patient is consuming alcohol continuously. What is acute alcoholic hepatitis?
It is.
Okay, so severe alcoholic hepatitis, they can present with fever, pain abdomen, jaundice, and ascites.
Yes.
Okay, so patient who are taking massive doses of alcohol continuously. So these are the differential diagnosis in your case.
Sir, any obstructive jaundice, obstructive.
So why you want to bring obstructive, which obstructive jaundice? Again, you are talking very non-specific. You have history, you have to tell me the diagnosis and defend it. Again, it is like broadly infective hepatitis type of your comment. What you mean by obstructive jaundice? Which obstructive jaundice? Where is the level? Which disease? Which obstructive jaundice will present with ascites?
Sir, any pancreatic cancer?
So what is the
Cancers.
presentation
Head
of CA head of pancreas?
That is mainly deep yellowish discoloration of the jaundice and abdominal distension, ascites, pain, abdomen.
No, that happens only when they have advanced malignancy. Usually pancreas, CA pancreas will present with pain abdomen, some jaundice, loss of appetite, loss of weight, and clinically progressive jaundice. There is no abdominal distension or ascites. Ascites will happen when there is a metastasis to peritoneum, and that called mild ascites again. Again,
Yes,
malignant ascites. How will differentiate ascites? Whether it is a portal hypertension related ascites or it is a non-portal hypertension related ascites. So non-portal hypertension related ascites are you get is like congestive cardiac failure, nephrotic syndrome, malignancies. Those type of ascites are tuberculosis. Those will not be ascites, will be massive. They will have mild ascites. Other systemic symptoms will be there. Okay, so that's how you will differentiate based on the presentation of ascites. So those will not present with predominantly with ascites until they have very quite advanced malignancy with peritoneal deposits developing ascites.
Okay, sir.
By that time, patient will be very terminally ill. So, ma'am, have any questions they can ask?
So can you like to list out only ascitic causes? If
Ma'am,
there is no
ascitic
pedal
causes.
edema, because you said the first 3 months it was only ascitis, right?
Yes, ma'am.
Yeah.
Maybe cirrhosis. The causes are cirrhosis of liver cirrhosis.
Only ascitis, only ascitis. Already sir has told us now everything. Just revise it once, I'm telling you.
Liver cirrhosis, some cardiac causes like pericardial constrictive pericarditis,
Yes.
and any abdominal tuberculosis,
Yes.
bacterial peritonitis, ma'am.
Okay. Okay.
Then any intra-abdominal masses,
CA peritoneal
CA peritoneum,
metastasis.
peritoneal
Or
masses.
peritoneal metastasis, you can have it, yeah. Any name is there for only
Yes, ma'am.
ascitis?
Meigs syndrome.
Meek syndrome is totally different. No, no. Only ascitis when you have. Ascitis precox, no? The name I asked you. Only when ascitis is there, it started for constructive pericarditis, used to call it ascitis precox. That was the name which we used to use only for ascitis, without any
Okay.
pedal edema or without any
Ascitis.
generalized edema features like that. Okay?
Yes, ma'am.
Yeah.
Acidic detox.
Yeah. What are the other causes for generalized edema? You have pedal
Ma'am,
edema
maybe
causes.
hypoproteinemia,
Yeah.
nephrotic syndrome. Then any protein deficiencies.
You said anemia, hypoproteinemia.
Mix.
You said nephrotic
Hypoproteinemia.
syndrome, liver
Myxedema.
cirrhosis.
Liver cirrhosis, myxedema, ma'am.
Myxedema, non-pitting it will be, no?
Yes, ma'am. Non-pitting.
Okay.
Nutritional deficiency.
Which deficiency?
Nutritional deficiency, ma'am. Hypoalbumin.
Okay. Okay. Anything else? The congestive cardiac failure.
Congestive cardiac failure.
proteinuria,
Congestive cardiac failure, ma'am.
that things. Yeah, yeah. Yeah. And what else? So 3 months of ascitis and then he has followed with fever and all. What do you think would have precipitated this? Three to 4 months of ascitis, then suddenly he has pedal edema, he has fever, jaundice.
Maybe malnutrition, ma'am.
Malnutrition, okay, one
Fever.
cause. Okay, you said no, that maybe he has some hepatitis or maybe he has decompensated.
Yes,
Acute
sir.
decompensation. No? There must be a chronic liver disease. He's been drinking alcohol for so long. Ascitis is one sign. Probably he was developing liver cirrhosis or portal hypertension, other in the pedal edema, then maybe he had an hepatitis or something.
Okay, ma'am.
Yeah, jaundice. And very important. Is it very important to find out if there is hepatitis in this case? Is it worth being hepatitis B, hepatitis C level, or just?
Yes, ma'am.
As
Because in
sir asked
alcohol.
you one question. Sir asked you one question. What is the percentage of people, alcoholics who develop cirrhosis?
Around, yes, ma'am. 30%.
No, it's only 15%. 10 to 15%, maximum 20%. Not many people develop cirrhosis. Otherwise, the government would have banned alcohol.
Yes,
Okay.
ma'am.
Yeah. How
Okay.
many hepatitis B people develop cirrhosis?
30%, ma'am.
No, a little above that, 40-45%.
40.
And hepatitis C is more than that. See,
Hepatitis
this
C more.
hepatitis B and C, both of them have got good treatment, and there is a conversion to hepatocellular carcinoma. That's the reason why we want to find it out if they have that. Alcoholic liver cirrhosis per se, not so much of treatment. Sometimes steroids, of course, otherwise transplant only. Only we treat the complication. That's the reason why we need to make out whether there is any other associated hepatitis also or not. That was the only thing I was thinking. Yeah. So we can see. So now you want to go ahead with the examination or?
Yes, she can.
Yes. Yeah.
On general physical examination, patient is conscious, oriented to time, place, person. Patient examined in supine position. Vitals are temperature 101 degrees Celsius. BP is 110/70 mmHg in supine position in right upper limb. Pulse rate is 129 per minute, regular in rhythm, normal in volume and character, no vessel wall thickening, no radio delay, no radiofemoral delay. All peripheral pulses are felt and equal. Respiratory rate is 20 breaths per minute, thoraco-abdominal, saturation 95% on room air, and no rise JVP. Also, icterus present, bilateral pitting pedal edema, which is extending up to knee, no pallor, cyanosis, clubbing, and lymphadenopathy. Facial puffiness is there, and parotid enlargement present, spider nevi present, no flapping tremor, no other signs of liver cell failure, skin, hair, nail appears normal, and spine normal. So from the history, most probably the liver pathology. So I would like to go with GIT examination first. Oral cavity examination, normal, and inspection, abdomen distended, flanks are full, umbilicus transversely stretched and everted. Distance between xiphus sternum and umbilicus is greater than between umbilicus and pubic symphysis. All quadrant of abdomen equally moves with respiration. Abdominal skin appears smooth and glossy, no scars, pigmentation and sinuses, no visible peristalsis, dilated veins and pulsations. Hernial orifices appears normal, scrotum and testis appears normal. On palpation, palpation is done after emptying the bladder in supine position with well-flexed knee. On superficial palpation, it is soft, vague tenderness present, no abdominal wall edema, no local rise of temperature, no guarding, rigidity, and rebound tenderness. On deep palpation, liver is palpable 1 centimeter below the right costal margin in the middle clavicular line. Sharp borders, smooth in surface, firm in consistency, non-tender and non-pulsatile. Spleen is palpable 2 centimeter left costal margin, smooth surface and non-tender. On percussion, liver dullness started from right fifth intercostal space. Liver span is 15 centimeter. Shifting dullness present, no fluid thrill. On auscultation, bowel sound present, no bruit and no venous hum. Other systemic examination, respiratory system first is normal breath sound present, bilateral basal fine inspiratory crust present and no wheeze. CVS S1, S2 present and no murmur. CNS examination, no focal neurological deficit. So the summary, 54-year male patient, diabetic and hypertensive with chronic smoker and alcoholic with significant ethanol consumption, presented with abdominal distension 3 to 4 months, and deep yellowish discoloration of the eye and dark colored urine for 15 to 20 days, bilateral lower limb edema extending to knee 8 to 10 days, fever for 5 days, and breathlessness for 4 days. On examination, patient is febrile, tachycardic, icterus, bilateral pitting pedal edema, facial puffiness, parotid enlargement, and spider nevi present. Abdomen is distended with vague tenderness, shifting dullness, and hepatosplenomegaly associated with bilateral inspiratory crux is there. So most probably the diagnosis is acute decompensation of chronic liver disease secondary to ethanol consumption with spontaneous bacterial peritonitis, likely to rule out hepatitis, not in hepatic encephalopathy, and diabetic and hypertension.
Okay. So why you say patient has SBP?
The patient had fever with
what you
diffuse,
got the point to say that is patient has SBP?
so diffuse abdominal tenderness is there, sir. With abdominal distension and fever was there, sir.
He has tenderness in the abdomen.
Yes, sir. Diffuse back tenderness was there.
Okay. And yeah, so how you will again the diagnosis is there is a difference in saying that chronic liver disease or versus cirrhosis. So do you think a patient has chronic liver disease is a vague terminology again? So my question is, do you think patient has cirrhosis? Yes or no? If he has cirrhosis, how you say that patient has cirrhotic on based on the examination?
Sir, first is from history, it is ethanol consumption is there, sir.
No,
Then on
now we
examination,
have come already moved on to the examination. Based on
on
the history and
examination,
examination, what are the examination point to suggest that patient has underlying liver disease,
yes,
chronic liver disease or cirrhosis? Chronic matlab, we are talking about cirrhosis.
yes, sir. Patient on examination, patient had jaundice and liver
Jaundice will not stay
hepatosplenomegaly.
cirrhosis. Jaundice can be anything else. What are the
Hepatosplenomegaly,
physical signs of cirrhosis?
sir. Liver cell failure signs will be there, sir.
Yes, that's I want to know.
Yes, sir. Liver cell failure like parotid enlargement and spider nevi is there, sir, with jaundice.
Okay.
Abdominal
Spider
distension with
suggests cirrhosis.
spider nevi suggests hepatic liver cell failure, sir.
Okay. How you test it and how they develop, why they develop, and where you will see look for it.
This is mainly due to absent hepatic clearance of estrogen. This estrogen will cause vasodilatation, sir. It is mainly seen in the above the shoulder part, above the nipple level, and it is will confirm by using a pinhead. It is presented like central arteriole, which is radiating some branches, sir, which is blanching while using a pinhead.
So he has one spider navy, second parotid gland enlargement. Is there any other signs of CLD in this patient?
Yes, sir. Liver span is increased and hepatomegaly is there, sir.
So in cirrhotic, liver span is enlarged or decreased?
Usually it is a decrease, sir, due to fibrosis.
Then how you say that is sign of cirrhosis? What else you have sign of cirrhosis in this patient?
In this patient, ascites is there, sir, shifting dullness.
Yeah, ascites is a usual indicator of that one. Splenomegaly.
Splenomegaly is there, sir.
Yeah, that's one indicative. And any other signs? You tell me other signs where you look for it and suggest the patient has CLD.
Sir, from this patient only this much
Yeah,
findings,
I
sir.
know this patient now. I am asking in general.
General. Sir, maybe gynecomastia. Gynecomastia, testis loss of axillary and pubic hair, testicular atrophy, and infertility in cases of women, and the temporal hollowness will be there, sir. Fetal hepaticus will be there, sir. Dupuytren contracture, palmar erythema, sir.
Yeah. So what is the acute
Thyroid
precipitating event? Why this patient? Is there any other differential diagnosis for fever and pain abdomen in this patient? So other differential diagnosis in this patient is alcoholic hepatitis. That's how they present usually what you call as acute on chronic liver failure. This is an entity new term. You can read about this. It is called ACLF. Okay. So ACLF means there is an underlying either detectable or undetectable liver disease going on, and there is an acute event which is happening over a period of 4 weeks. So in this group of patient, how they usually present with, they're drinking continuously, they develop acute alcoholic hepatitis, which can
Yes.
present with fever, pain, abdomen, and hepatomegaly. So that is
Okay,
what
sir.
in this patient, there is continuously drinking, developing jaundice, developing fever, then hepatomegaly, tender hepatomegaly you can get
Will
sometimes.
be. Yes, sir.
That is precipitating underlying chronic liver disease that's going on for many years, tilting it balance, developing a acute decompensation in the form of ascites and jaundice. Some of
Okay.
they can have encephalopathy and GI bleed.
And-
So
Okay, sir.
this is called ACLF.
Okay, sir.
Okay. So first of all, you have to tell patient has cirrhosis like portal hypertension that is related to cirrhosis of liver, and etiology of cirrhosis is alcohol, probably
Alcohol.
because of in doses what we consider. That is one possibility, and that
Okay,
has
sir.
lead to a decompensation called
Mm.
decompensation in the form of ascites. That is, you right tell that patient has cirrhosis of liver, that is, and there is a decompensation with in the form of ascites, and acute event in the form of what is the acute event which is precipitated in this patient is probably has an acute alcoholic hepatitis.
Alcohol.
That's what it is caused. Now,
Okay, sir.
third, you have to always tell complications.
Yes, sir.
Complications of cirrhosis and ascites. So cirrhosis of ascites complication, one differential diagnosis you can keep the patient as probably SBP
Hepatic
because of
SBP,
fever and
fever.
pain abdomen and tenderness and examination. That's it.
Okay, sir.
And these are the how, and in detail you have to always tell about the nutrition in these patients, whether they usually most of them will be sarcopenic, and always take detailed history of the nutrition history, and examination also you not examined related to nutritional, so that you
Okay.
cannot go away from exam history also, and in clinical examination nutrition is very very important in this group of patients.
Okay, sir.
Okay. Okay. Ma'am, anything else?
Mm. Can you make out from a general examination what is the cause for the liver dysfunction? Like you said, the parotid enlargement, difference for the alcohol as a cause, right? For chronic liver, anything else that you can find out? I'm asking what are the causes of chronic liver disease and how you can find it on a general examination.
Yes, ma'am.
So for alcohol, you already said. So other causes, what are the other causes of chronic liver disease?
Hepatitis C, ma'am. Any other causes are genetic disorders like Wilson's disease,
So Wilson's disease,
hemochromatosis,
what will you look at for general examination?
KF ring, ma'am. KF
And
ring.
anything else?
Generalized pigmentation in hemochromatosis. And
So
tremors will be there.
In
Fine
hemochromatosis,
tremor.
what will you get?
In
In your
hemochromatosis,
examination, what will you get? Yeah, correct.
black pigmentation will be there, ma'am.
Yes.
Then tremors are there. Wine beating tremors will be there.
Diabetes you'll have, no? Hemochromatosis.
Diabetes, Brown's diabetes.
Hyperpigmentation, yeah.
Hyperpigmentation and arthritis will be there. Arthritis will be there, ma'am.
Arthritis, not so much common. Okay. Then what about NASH? What will you get? NASH is one more reason for liver disease, right? Chronic liver disease.
Xanthomas will be there. NASH.
Okay.
Xanthomas. Abdominal obesity.
Yes.
And
Acanthosis
some
nigricans.
acanthosis nigricans. Some striations will be there in abdomen.
Yeah. So you look like this at different causes. And then like if
Yes,
you have an autoimmune hepatitis, you can look at some joint pains, some rashes. The patient is on regular medications, methotrexate. So you can make out that he has rheumatoid arthritis, then methotrexate induced liver disease, like that. Find out the cause for liver disease and find out what they have in the general examination. You can find it. That is one thing. Yeah.
Okay, ma'am.
And so as sir has said, so what is the final diagnosis? How will you present this case now? What's your final conclusion marks?
My final conclusion is acute decompensation of the chronic liver disease, most probably cirrhosis. The cause will be alcohol ethanol consumption with complication of spontaneous bacterial peritonitis.
So the decompensation is in the form of
Decompensation in the form of jaundice and ascites.
ascites was an old problem. Jaundice.
Ascites and hepatosplenomegaly.
Okay. No GI bleed he has, right? No hepatic encephalopathy.
No, ma'am, no flapping tremor. Patient was conscious, oriented, and there is no history of sleep disturbances. There is no history of melena and black colored white fresh blood in stool.
Okay. What are the acute decompensation that you look at in a patient of chronic liver disease? What are the things that you look at?
Acute
You already
decompensation.
said it. Yeah, you said it. You can just revise it once. Tell what are the acute decompensation. Yeah.
Jaundice, ascites, and breathlessness and fever.
Yeah. What about upper GI bleeding, hepatic encephalopathy? These are all
There is
signs.
no
Hepatorenal syndrome.
signs. Upper GI bleed, hepatic
Acute
encephalopathy.
decompensation. I was asking what is the acute decompensation? Not in this case, general case. I was asking. Yeah. Yeah. Anything else, sir?
Yeah.
Otherwise,
So-
you have to know all the pathophysiology of each of these things, why it happens.
Yeah. So
The spider
usually
leg.
in the 50 years of age group, as you said, alcohol you're taking just because he's taking alcohol. So what do you think are other causes of cirrhosis in this 50 years of age group?
There may be hepatitis.
So after alcohol, what are the common, you just enlist the causes of cirrhosis in 50 years age group?
Sir, alcohol, hepatitis, genetic causes like Wilson's disease, NASH, then alpha antitrypsin deficiency, sir,
That's what
hemochromatosis.
I told you is 50 years. So most
50.
common, the common causes for cirrhosis is alcohol. Second, he has diabetes, hypertension. You should always tell NASH is the second possibility. Third possibilities are viral illness, hepatitis B and C.
Viral.
More common. So in drug
Yes.
abusers will be hepatitis C. If non-drug, hepatitis B is common in Karnataka, but hepatitis C we don't see because it is seen in usually in drug abusers. Okay.
Yes,
And other possibilities, hemochromatosis, Wilson disease will not be this presenting age. They are extremely rare at this. They will start very early age. Usually,
Yes, sir.
Wilson's is routine age of presentation is very childhood or young adult, not in 50 years of age group. Okay.
Okay, sir.
Alpha, you are all genetic disorders or autoimmune disorders or like cholestatic liver disorders. These will present quite early rather than late, and autoimmune disorders are common in females. Okay. So always in this group, you have to keep three possibility: alcohol, NASH, and virality.
Vitamins.
As the possibilities. So how you will evaluate this patient?
Sir, basic examinations like CBC.
So
In
what you are,
CBC,
and in brief and quickly, you have to tell me what you are looking at and what you expect in this in the reports in this patient.
sir,
First, you have to confirm your diagnosis. Okay. So what test you do to confirm your diagnosis?
LFT, sir, first. LFT, the total bilirubin will be raised, and we'll check for direct and indirect bilirubin. And SGOT, SGPT will be elevated. For alcoholic patient, SGOT, SGPT ratio will be more than 2, and ALP will be raised, and the gamma glutyl transferase also will rise. And peripheral.
First, you have to confirm your cirrhosis. How you will confirm your cirrhosis based on the LFT? What are the tests you do? Biochemical test to confirm cirrhosis. Is there any clue to it? This one you get on the LFT to say that patient has cirrhosis.
Sir, direct bilirubinemia will be there, sir. More.
Okay.
Direct hyperbilirubinemia, and ALP
So
will be
patient
rise, sir.
can have cirrhosis,
Which is
patient
the
can have
sign of
normal
chronic
bilirubin.
liver disease? Liver function like chronic
Can a
liver disease.
patient
already.
of cirrhosis can have a normal bilirubin? Yes, no.
Yes, sir.
Then
So which
so
test
bilirubin
tells
is
you
not
that it is
next.
chronic in the liver function test?
PT-INR, LV,
LFT.
And one more.
In the LFT, you have
more.
to tell me.
hypoalbuminemia will be there, sir. Albumin will be low.
Hypoalbuminemia, AST more than ALT are the two things which will suggest. Other
Yes, sir.
biochemical, you have to say prolonged PT-INR. So any other
Okay,
test
sir.
you want to do?
Yes, sir. Sodium, potassium, sir. Hypokalemia will be there.
Why you expecting hypokalemia? Quickly. Okay, so other test you have to do, confirm your diagnosis. Now, what is CBC? What you expect in CBC?
In CBC, sir, the thrombocytopenia will be there.
That's what
And
we look for. Do the CBC, look for the.
macrocytosis also.
So look for MCV, look for hemoglobin, look for
Hemoglobin.
the platelet count. Even some patient can have, because there is a splenomegaly. We expect him to develop leukopenia with thrombocytopenia. So how further, what a test you want to prove your diagnosis?
USG abdomen, sir.
So what do you expect in that?
Macro nodules will be there. Ascites
That is
will be there.
pathological diagnosis.
Liver size we will get, sir. Shrink.
Liver size may be normal, may be enlarged. That will also now tell you the cirrhosis. In autoimmune, it will be enlarged. In completely cirrhotic, it will be small. So how the size will tell you? What else you expect? So in ultrasound, there are 3-4 features which suggest patient has cirrhosis. One is nodular outline liver, not size. Second, splenomegaly. Third, portal vein size. Fourth, portal collaterals. If there is a collateral, it indicates portal hypertension. So you look for the signs of portal hypertension on the ultrasound, or there is a lobular disarray in the liver. So either left lobe atrophy, right lobe atrophy, or nodular outline will suggest that is a cirrhotic changes. And other look for portal vein, stents, splenomegaly. These are the signs on the ultrasound. Next test, what you will do?
Sir, liver biopsy?
No. Why you will do biopsy when you are suspecting this one? How it will tell you what will become, what you get more information on biopsy? You're already suspected cirrhosis, no?
Yes, sir. But to
So
rule
you
out portal CECT
have
abdomen,
other
sir.
complications, no? Ascites is there, no?
Yes, sir. Ascitic fluid analysis, sir.
So that is the most important thing.
Ascitic fluid analysis.
So which test you will do it and how you will interpret?
Sir, in ascitic fluid analysis, SAG we will check, sir. Serum ascitic albumin gradient, sir.
Yeah.
In portal hypertension, due to cirrhosis, the SAG will be more than 1.1. And other causes, non-portal hypertension cases, it will be less than 1.1, sir.
Yeah. That's what. And
we will
look
get
for
idea.
You are looking for your SBP also, look for the count. If there is a SBP,
yes.
so you have to listen. Okay. So we'll manage this case.
Sir, general management first we will do, like first abstinence of the alcohol, then maintain the nutrition and low protein diet with supplementation.
Low protein diet?
1 to 1.5 gram per day.
So
sir.
that is low protein. What
It
is
is
high
a normal protein. Normal 1 gram per day, sir.
No. Okay. So next anything, I will tell you about that.
Okay, sir.
Next anything. Okay. So usually before going ahead, always do endoscopies in this patient. Look for the varices always. Okay. So that's other test you do it. Confirm your diagnosis. As these patients have underlying other problems like viral etiology, always do hepatitis B and C. Get your PT-INR, look for creatinine because you need to start them on diuretics. So do the RFT, viral markers, ascitic fluid analysis, one ultrasound and endoscopy. These are the tests. Once you are done and you confirm your diagnosis as a cirrhosis and etiology as alcohol, then most important, as you said, nutritional, diuretics, and some supportive medicines
Some
because
supporting
they are
medicines.
at the micronutrient deficiency. So add some multivitamins. They are at thiamine deficiency. Please give some thiamine. Okay. So start them on diuretics. So in always in nutrition, you have to give them very high protein diet, not low protein. That is earlier concept. Now you have to give high protein diet, salt restricted. How much is the salt you give them?
Less than 2 gram per day, sir. 2 to 3
No,
gram per
wrong.
day.
No. So 4 to 6 gram. So how you measure that one?
Teaspoon.
Yeah,
1 teaspoon.
small to
1
medium,
teaspoon
not
is
what you. Yeah. So around 4 to 6 gram of sodium per day you have to give them, and no water restriction until sodium is okay. So high protein diet and diuretics and nutritional supplementation for few days.
yes, sir.
So anything, ma'am?
As a family physician, what would you tell them? How would you counsel them?
So, ma'am, first alcohol abstinence. Then I'll explain about the high protein diet, sodium restriction, and calorie intake to about the malnutrition and multivitamin tablets. I'll advise. Then
Will you tell them about complications? How to
yes,
avoid those
yes, ma'am.
complications? Yeah. Go ahead. Tell.
Is complication. Yes, ma'am.
What are the
Complication,
complications that you will explain to them? How they can avoid it? How they can observe it? What are the complications of the cirrhotic liver? Simple. You already spoken.
malnutrition.
No, you said something about hepatic encephalopathy and all, right?
And yes,
So
ma'am.
you can talk to them about that also, that it may happen. So what can they do to avoid hepatic encephalopathy? Simple things from their side.
Hepatic encephalopathy, stool, passage of stool, lactulose I'll advise, ma'am, to avoid constipation.
Yes.
And high low dose diuretic I'll prescribe because it will cause hypokalemia.
Yes.
Then prophylactic rifaximin I'll give to prevent the SBP.
Rifaximin,
Rifaximin.
that is only in hepatic coma or something else, not for this reason. For SBP prevention, they use something else. Sir, Dr. Mallikarjun, they use the prophylaxis nowadays for SBP?
No prophylactic. When you have prophylactic SBP,
norfloxacin being given for a long time. Is that a new
every
guideline?
patient. Yeah, there is not for every patient. There is a recommendation for that. Patient who has SBP with very low protein in the ascites, and second is they have built up in more than 3 or creatinine is more than 1.5, and those type of developing ascites you give prophylaxis, norflox or rifaximin. And encephalopathy also, there is no prophylactic encephalopathy. Once they develop encephalopathy, you start treatment, and long term for prevention you can give. But underlying just with cirrhotic does not mean you should start them on lactulose and rifaximin for prevention of encephalopathy. No, that is not recommended. Once they develop encephalopathy, you start, but further recurrent episode, you can start on prophylactic lactulose and rifaximin. Thank you. Nice presentation.
Yes, good one.
Thank you.
Yeah.
Yeah. Yeah, Fatima, good presentation.
Thank you so much. Thank you, ma'am. Thank you so much, sir. We had a very interesting discussion, and definitely, I think all the PGs would have gained a lot of information on how to present and how to, I think, arrive at the diagnosis and what has to be done. Thank you so much, Dr. Fatima. It
Thank
was
you,
a
ma'am.
very nice presentation. Thank you all for attending. I hope everyone
Yeah.
found the session useful.
Yes. Thank you, Dr. Suprit. Yeah.
Thank you, ma'am.
Thank you.
Thank you, Dr. Mallikarjun. Thanks,
Thank you.
Fatima, for the
Thank
nice
you.
presentation.
Thank you, Dr. Mallikarjun. Yeah.
Thank you.
Thank you, sir. Thank you. Good night, everyone.